So grade 3 diastolic dysfunction, as we know that there is decreased LV compliance and there is increased left atrial pressure at the baseline. So the left ventricular and diastolic pressure will be very much high. If you give even very less volume, there will be very high increase in the left ventricular and diastolic pressure, because as we have discussed previously, the pressure volume loop is shifted upwards and leftward. So even a small increase in the filling volume can cause significant increase in the end diastolic pressure, leading to the congestion and symptoms. So a careful perioperative fluid management is very much important, and these patients requires invasive monitoring. A higher mean arterial pressure may be required to increase the coronary perfusion pressure. As we know, the coronary perfusion pressure is mean arterial pressure minus left ventricular and diastolic pressure. In these patients, left ventricular and diastolic pressure is already elevated. So to maintain the coronary perfusion pressure, we must require that mean arterial pressure should be increased. So always increase the mean arterial pressure in these patients, and treat hypotensions with vasopressors and antidilators instead of fluid. So this is a stage of preload intolerant. That is, even a small volume can cause symptoms, and this stage is preload tolerant stage, as coronary perfusion pressure depend upon the map. So preoperative screening, always when the patient comes to the preoperative room, risk stratify these patients and identify the patient with higher grade of diastolic dysfunction, like female patients, elderly who have untreated hypertension, diabetes mellitus, ischemic heart disease, and obesities. Try to assess their functional capacities by the metabolic equivalents, and always try to find the evidences of the diastolic dysfunction in the echocardiography. For example, left ventricular hypertrophy and increased left ventricular filling pressures. Perioperative optimization. If these patients are on the renin-angiotensin-aldosterone system inhibitor therapies, so if they are given for the hypertension, you omit 24 hours before the surgery because it can cause hypertension. If these medicines are given for the reduced ejection fraction, you can continue these medicines by strict vigilance. Continue the drugs for the treatment of the heart failure, arrhythmias, hypertension, and continue the statins. Now, this is very important. If you are inducing a patient with grade 3 diastolic dysfunction, always reduce the induction dose by 35 to 50%. Avoid cardiodepressant drugs and prevent perioperative MI to slow down, because it slows down the myocardial relaxation and can induce arrhythmias. You can induce this patient with titrable dose of etomidate because it does not affect the systemic vascular resistance. In grade 3 diastolic dysfunction, these patients usually require invasive monitoring like pulmonary artery catheter and transesophageal echocardiography. Avoid the factor that can affect the diastolic time like tachycardia and arrhythmias. Control the blood pressure within 20% of the baseline. Now, this is very important. Always follow the rule of 70. That is, in the patients with more than 70 years, keep the diastolic blood pressure more than 70, keep the heart rate equals to 70, and pulse pressure less than 70. So this is very important. So monitoring, there are vast ways you can monitor these patients. Arterial blood pressure, central venous monitoring for vasopressors, anatropes. And more important is that in the patient with grade 3 diastolic dysfunction, try to insert pulmonary artery catheter, and transesophageal echocardiography, the single best tool which can help you to monitor diastolic dysfunction operatively, because it helps to answer the two questions, that is, do I need more volume or have I given enough volume? This you can see by the single loop, that is gastric, transgastric, short axis view. By this view, you can assess that whether you have given enough volume or you require less volume. It also helps real-time assessment of the diastolic dysfunction.